Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
Hello, I'm Dr. Sharon Cohen, neurologist and medical director at Toronto Memory Program in Toronto, Canada. Welcome to this case-based discussion on linking cognitive testing with biomarker testing in Alzheimer's disease. Joining me today are Dr. Gregory Jaika, who is a professor of neurology at the Sanders Brown Center on Aging at the University of Kentucky, and Michelle Mielke, who is chair and professor in the Department of Epidemiology and Prevention at the Wake Forest University School of Medicine. Welcome to you both. During the next half hour or so, we'll discuss how to combine cognitive and biomarker testing in establishing a diagnosis of Alzheimer's disease, using cases to help illustrate points. First, Greg, can you give us an overview of the current guidance on diagnosing Alzheimer's disease?
Sure, Sharon, I would love to. We do this all the time, but actually thinking about these 7 steps, which really are the current guidelines when incorporating biomarkers and ultimately coming up with a diagnosis. So, the first thing when a patient comes in, step one, is to establish shared goals for the diagnostic process. Really, really important because, of course, we're going to tailor this to what is best for the patient and taking their opinions into account. And then, of course, as with all medical encounters, we're going to take a history. Really important at step 3 to do a multi-domain systems review. We really want to look for medical conditions that could be impacting cognition or responsible for the patient's symptoms. We also want to know about affiliated symptoms that may be related to the underlying possible degenerative or vascular disease type, things like sleep disorders, signs of Parkinsonism. Of course, social history and risk factors, incredibly important as we're pulling this all together. And that brings us really to the heart of the visit, although by this point, by the time we're done with level 4, we should have a pretty good idea of where we're going. Then we're going to conduct the exam, a general medical neurologic screening examination, focusing in on any areas that the patient might raise as issues for them. And of course, embed in that some sort of cognitive screen measure. Really, really important. If we're going to move on with diagnosis and or treatment decisions, we really need to tease out, is there a cognitive problem here? Core 6, we're really going to decide, what do we need to order? What are our diagnostic laboratory tests, imaging, and or other tests that we may want to order to fill this out? And lastly, and most importantly, we really want to communicate those diagnostic findings and their implications for treatment and prognosis to both the patient and care partner. And I think most of this, as practitioners, we all understand. Sometimes people get a little tripped up when it comes to the different cognitive, behavioral, and functional measures we may wish to use. So there are a variety of them out there, several questionnaires that can help to guide us and give us scores, and then brief memory screening tests, mini cog, mini mental, Montreal cognitive assessment, the slums and digital tools. We have many functional measures as well, and we should never forget the behavioral manifestations that are often linked to cognitive decline and memory problems. I highly advise that you take a look at this myriad of measures and find the ones that work best in your practice. First off, we want to make sure that we are looking for the underlying causes of cognitive impairment. And built into this is really to look for non degenerative or non vascular causes. They are just as important to search for when you're getting started as jumping right to, oh my goodness, I think this is Alzheimer's disease. We certainly don't want to miss anything. So, a general medical review, comorbidities, medication review is really, really important. We want to really focus our neurologic psychiatric examination. Is there a hearing problem or vision issues? Are there physical signs of Parkinsonism or motor neuron disease, focal weaknesses like a stroke, and then, of course, some basic laboratory tests, a comprehensive metabolic panel, a CBC, thyroid functions, B12 and folate levels are part of a standard workup recommended by the American Academy of Neurology and most other medical institutions. We always want to make sure we get structural imaging. So an MRI is much preferred over a CT scan if we can get it. And we're looking for abnormalities. Have there been strokes? Is there a tumor? Is there a normal pressure hydrocephalus, too much CSF? And really, we can begin to start to use that imaging to actually look at specific atrophy patterns that may signal a degenerative disease.
Thank you, Greg. That's so comprehensive and so important. We don't want to miss things. We don't want to overdiagnose. We don't want to underdiagnose. And so, if we think about Alzheimer's biomarkers, how do these add context on the background of already having completed history, cognitive testing, etc.? Well, we come up with a clinical syndrome. When we take a history, we listen to the complaints, we examine our patients, we get some cognitive testing done, and we can say somebody's cognitively unimpaired. Maybe they have symptoms, but their testing's normal, or they have mild cognitive impairment with objective evidence of impairment, but still functioning independently, or they've lost some independence in day to day function. They have cognitive impairment and either mild, moderate, or severe dementia as their syndrome. But what is causing the clinical syndrome? And although there may be clues and we may have a strong assumption that cognitive impairment is of an Alzheimer's phenotype or that we have probable AD dementia, we are not going to be precise enough for clinical syndromes alone. And that's where biomarkers come in. So, why measure biomarkers in Alzheimer's disease? Well, as we've said, you can only go so far with your clinical assumptions. And if you want a definitive confirmatory diagnosis, you need biomarkers. And you would need this to give a person a clear understanding of what they're dealing with, allow them to plan ahead, to avail themselves of both pharmacologic and non pharmacologic therapies. And in terms of pharmacologic therapies, they may be eligible for a clinical trial that they're interested in, or they may be eligible for amyloid targeting therapies. We're now in the era where we have for early AD, so the MCI and mild AD dementia stage, some new therapies that can slow down disease, but we need to know the amyloid pathology is there. So, who should we test in Alzheimer's with biomarker testing? Well, symptomatic patients, especially if they're at the early AD stages by our clinical determination, we want to know if they have a treatment opportunity, but also patients with an atypical presentation. Maybe it's non-amnestic presentation. Maybe it's primarily a language presentation or a visual variant of Alzheimer's, we're assuming. But again, those patients may have less of the typical phenotype of Alzheimer's, so biomarkers can be very helpful. Patients with young onset Alzheimer's, often called early onset dementia. We don't want to just reach for low hanging fruit. This is menopause, this is life stress, can't sleep, working too hard. Biomarkers can be very helpful. And then patients with uncertain dementia, where the clinical syndrome is really unclear and there may be a number of different possibilities that may be contributing to cognitive complaints, but we don't have a clear handle on it. So, as far as biomarker test modalities, we're fortunate that we have three broad modalities for Alzheimer's diagnostic biomarkers. We have amyloid PET, CSF biomarkers, and plasma biomarkers, and they all have their pros and cons. Amyloid PET is generally reported as positive or negative, but if we're lucky, we may have a PET center that reports using a quantitative scale, the Centiloid scale. Disadvantages of amyloid PET: high cost, radiation exposure, and limited availability. With spinal fluid testing, we have high degree of alignment with amyloid PET, and we have a number of different analytes that we can measure in a single sample of spinal fluid. And for diagnostic purposes, low A beta 42 over 40 or high p tau 181 over A beta 42, 17. There's a long list of biomarkers that change around the same time that amyloid PET becomes abnormal. Disadvantages of CSF biomarkers: the perception that this is an invasive procedure, although the reality is most patients tolerate an LP well, but we do need trained healthcare professionals to be the operators. And some patients, even if they're willing, will be on anticoagulants that they can't pause or will have spinal deformities, which will make it challenging and unwise, perhaps, to perform an LP. And then we have plasma biomarkers, which we've been waiting for a long time. And the reality is they are here, and there will be more to come. And these are the great equalizers in terms of greater access for populations in rural and urban areas, less costly. And now I'm going to turn to Michelle, please, to talk a little bit more about blood biomarker testing and how it relates to other biomarker modalities.
Yeah, thanks, Sharon. It really is an exciting time in the field to have blood-based biomarkers because, as you said, they're less costly, more accessible, more feasible in rural areas as well as also urban areas. Now, there are a number of blood-based biomarkers that are available, and oftentimes the blood biomarker that will be available to you will depend on the health system that you're involved in and also what's available to order in the electronic health record that you use. All of these are approved in terms of an in vitro diagnostic. In addition, there are two blood biomarkers now that have received FDA approval. The first one is the Lexis p-tau 181. This is to aid in the initial assessment for Alzheimer's disease for patients that are 55 years and older with symptoms of cognitive impairment. A negative result is suggested to rule out Alzheimer's disease, but a positive result suggests that additional testing is needed. There may be potential for false positives, which is why additional follow up is needed. The other test that is available is the Lumipulse Sphin A beta 42 ratio. This is approved to aid in the diagnosis of Alzheimer's disease pathology among individuals that are 50 years and older and that have cognitive impairment. In contrast to the p-tau 181, a positive result does suggest the presence of amyloid pathology. And I do want to mention there is also the p-tau 217. Again, this alone is not FDA approved, but the p-tau 217 test alone is widely clinically available. Now, both of these markers, p-tau 181, p-tau 217, and also the ratio, has been shown across a variety of studies that they can separate individuals who are amyloid PET positive from individuals who are amyloid PET negative. And they do have high concordance with amyloid PET as well as in general CSF markers. The Global CEO Initiative has recently put out recommendations for use of these blood biomarkers in clinical practice. A key aspect of these recommendations, as was mentioned earlier, is that individuals first have objective evidence of cognitive impairment. And so it's not just subjective symptoms. You might have heard of these tests as being either triaging or confirmatory. A triaging test, similar to what I just talked about with p-tau 181, is a test such that if there's a negative result, that generally rules Alzheimer's disease pathology out because there's a 90% sensitivity, but the specificity is lower. And so this means that there could be some potential false positives and warrants additional follow up with testing, such as with CSF or amyloid PET. In contrast, confirmatory tests have high sensitivity and high specificity and could potentially be used in place of CSF or PET. However, I do want to point out that most of the work in terms of looking at these biomarkers from a sensitivity specificity perspective have been done in specialized clinics and have not generally been done at the population level, including in primary care or general neurology clinics. And so we don't fully know what the accuracy of these blood biomarkers are in those settings. And so it may be important, even for a test that's determined to be a confirmatory blood test, that additional follow up might be needed. Now, depending on the test that you use, some will have one cut point, so it's either abnormal or normal. Others will have two cut points. In the case of two cut points, you end up having a low range, an indeterminate range, and a high range. And if somebody's in the low range, it's very highly suggestive that the person does not have amyloid pathology in their brain. If they're in the high range, it's generally suggestive that they do have amyloid pathology in their brain. However, if they're in the intermediate range, this is generally the group that you are definitely going to have to do a follow up CSF or amyloid PET to confirm whether this individual does have amyloid pathology or not. So it's important to think about when these blood biomarkers should be used and when they shouldn't be used. So first of all, as I mentioned, as did Sharon, it's really important that patients only with objective evidence of cognitive impairment should have a blood-based biomarker. And further, it should be used in combination both with the clinical and cognitive evaluation. So if somebody comes in cognitively normal, has a blood biomarker, and it comes back positive, that might be indicative of underlying pathology, but it doesn't mean that somebody's going to develop cognitive symptoms or necessarily be predictive of disease progression. And so, in addition, if somebody has cognitive impairment and you have a strong suspect that Alzheimer's disease may be the underlying cause, that is when it would be certainly appropriate to do or to utilize these blood based biomarkers. And then, lastly, in terms of appropriateness, you want to use it when the test will help influence clinical decision making. So, we've talked about when testing is appropriate. There are also situations when blood biomarker testing is not appropriate. So, first of all, there is a lot of research out right now looking to see if these blood biomarkers can predict when an individual will develop cognitive symptoms. However, for an individual patient right now, we cannot tell them, given your blood biomarker level, when you will ultimately develop cognitive symptoms. And we know that many people end up dying and they have lots of plaques and tangles in their brains, but they actually never developed cognitive symptoms. So currently, we don't want to use these as a predictive biomarker for becoming symptomatic. In addition, it's not necessarily appropriate to use it for individuals 75, 80, and older whose family members want to know if they have Alzheimer's disease pathology, particularly if they're not eligible for monoclonal antibodies or other types of Alzheimer's disease treatments. And the primary reason for this is that we know that Alzheimer's pathology starts decades before clinical symptoms. And generally, by the time a person with dementia is 75 or 80 years old, they're not only going to have Alzheimer's pathology, but they're going to have multiple other pathologies. It's very unlikely that they have pure Alzheimer's disease. Unfortunately, at this point in time, we don't have blood biomarkers for some of these other pathologies. And so there could be a potential overfocus on Alzheimer's disease. And then lastly, we know that there are certain chronic conditions, particularly chronic kidney disease or renal dysfunction, and obesity can alter these plasma biomarkers. And so, particularly with poor renal function, it is possible that you could get a false positive result in these individuals, and that would warrant either not using the blood biomarker for those with very poor renal function or the need to have confirmatory testing with PET or CSF. And then I think it's also important to highlight why we have said that it's important to only use these biomarkers for individuals that have objective cognitive complaints and not among cognitively normal individuals, for example, with a family history. First, we don't recommend using among asymptomatic individuals because there is a low positive predictive value. Um, in addition, and this varies by country, but in the United States, if a biomarker comes back positive among an individual that is cognitively normal, they could face discrimination in terms of refusal for long term care insurance, life insurance, disability insurance, and also some senior housing. So it's important to talk to the patient about this beforehand.
Thank you, Michelle. That was very comprehensive. Before we discuss our cases, I invite our audience to pause for a moment and think about any of your patients for whom knowing the results of both the cognitive testing and biomarker testing could better inform your approach to providing care. Please feel free to pause the video if you wish to give this some thought or write something down, and then restart the video when you're ready. Okay, let's move to some cases now. Here's our first case. This is a 72-year-old woman. She's been reporting memory problems that started 2 years ago, and she recently got lost on her way home from the grocery store. She's no longer able to manage finances. Her daughter reports that she repeats herself a lot and she forgets to pay bills. So we've got some clinical information. We don't have cognitive test results. Greg, maybe I can throw this to you. What would you still want to know about her and where would you go with this?
Yeah, this is certainly a typical patient that I might see in my memory disorders clinic. And there are a lot of bells going off here that are pushing me towards, oh my goodness, it sounds like Alzheimer's disease. But again, that can be a trap because we don't know yet what else is going on. Have there been particular stressors? Are any of her medical conditions out of control? Again, I think we really need to go back to the basics here. We need to take a little more thorough history, tease out with some of our cognitive and functional assessment tools. Where are we in the grand scheme of things? And certainly send for that standard blood work to look for medical causes, imaging in the brain. While fortunately not common, it also is not incredibly rare either that I will have a patient present with this. And when I take a picture of their brain, they've got a huge stroke that the family never knew that they had in their frontal lobes, or even infrequently a brain tumor. But I do think once we're done with this standard workup and really tease that out and go through our examination, this is a case that we potentially would want to pursue further biomarker testing. I'd love to hear your thoughts on that, Michelle or Sharon.
Sure, I'll turn over to Michelle in a moment as our biomarker expert, but you're quite right, Greg. You know, at first blush, we're in the age group for Alzheimer's. Memory is a predominant symptom, it's slowly progressive, and it sounds like she's losing function, which is driven by the cognitive decline. And let's say we rule out sleep apnea, strokes, where, routine blood work shows normal B12 and TSH, and a structural brain scan is normal. Then we're really thinking probable AD dementia, mild would be my syndromic diagnosis. But Michelle, help us take it a step further here because probable mild AD is not good enough.
Right, right. So this would be a case once you confirm the cognitive impairment, and I do want to highlight that again, just with a general screening test, because families can report different things about their family members. Then a next step would be to do the biomarker testing.
And I would think from um, the little we know about this patient right now, we're sort of wide open. She could have PET amyloid imaging, CSF, or blood based biomarker. We don't have anything to say that one or the other uh, would not be suitable. But of course, there are other factors in terms of cost and access, etc. Let's say this patient comes back with a positive biomarker. Let's say she's PET amyloid positive. What would you tell her and her family? Greg, do you want to take that?
Yeah, this is really where we have to be quite clear on what that means. So, certainly when we're dealing with an amyloid PET scan, that's fairly definitive evidence, if it's positive, that yes, indeed, there's a buildup of amyloid plaques in the brain that are being picked up on. What we don't know are some of the other things that Michelle alluded to. We don't know if there's other comorbid pathology or contributors to that. But this is core biomarker criteria that suggests that Alzheimer's is at least a contributing biological cause, if not the major cause for this patient. So I think we have to be tactful about that. Sometimes the approach would be altered if that test came back negative for all intents and purposes. But in this case, I think we can move forward. I think we have to be respectful of this. There are going to be a lot of questions from the patient and the family, and we're going to need to understand where they want to go. We're also in a position to add symptomatic therapies, perhaps a cholinesterase inhibitor or a glutamate partial antagonist. But really, this sounds like a person who may be getting lost on the way home from the grocery store, but she's still driving. Early stages of Alzheimer's disease, she is an ideal candidate for consideration of anti amyloid therapy. And that may open up additional testing that we didn't do originally that now we may need to pursue. What I found in practice is that once you actually lay out those biomarker test results, you can talk about a lot of things, but the patient and the family are really going to chew on that one piece. And so it may be an appropriate time to relay those results and schedule a follow up in the near future within the next few weeks if you have the capability to do so, so that you can fully address the complexity of how the patient and the family may want to proceed with this.
Yeah, so interesting and well put. These discussions take time, as you've explained, Greg, and it's not a one-shot conversation. Having put aside enough time to discuss the result, as well as having the important family members, if that's relevant, at the table, goes a long way to reassure patients that we're listening to them, and also that the fear and dread of an Alzheimer's diagnosis, biologically confirmed diagnosis, is somewhat mitigated by the many treatment opportunities, pharmacologic and non-pharmacologic. And you talked about cholinesterase inhibitors and maybe amyloid-targeted therapies. Maybe we'll go on to the next case now. Here we have a 60-year-old gentleman, well-controlled hypertension, cognitively unimpaired, presumably by a cognitive screening test he scored in the normal range. His father has probable Alzheimer's disease dementia, and symptoms began in dad at 65. Paternal uncles and aunts also have evidence of cognitive impairment, and our patient is concerned that he might have Alzheimer's and he wants to get tested. Michelle, let me ask you, where would you go with this?
Yeah, this is a perfect case that I was talking about earlier. Again, I can understand from the patient's standpoint that they're worried about developing Alzheimer's disease given their family history. But there's also a good chance that they won't develop Alzheimer's disease. And this person is currently cognitively unimpaired. As I mentioned, a blood biomarker cannot tell for an individual person when they will develop symptoms or even if they will develop symptoms in their lifetime. And so at this point, it would not necessarily be appropriate to have the blood biomarker. I think a better aspect would be to follow them up, do cognitive screening perhaps every year or every other year until you see that there are some cognitive changes. And then you could go ahead and try the blood biomarker. And I think it's also important to note that the current monoclonal antibodies are only for individuals that do have a diagnosis of mild cognitive impairment or Alzheimer's disease. And so, again, even if this person happened to have a blood test or an amyloid PET and had confirmed amyloid pathology, they still would not be eligible for those treatments.
Yes, totally agree. And of course, this may change in the future if the current preclinical AD trials read out positive with monoclonal antibodies, then we may be treating individuals like this gentleman and therefore may need biomarker evidence of pathology. But right now, as you say, Michelle, this is not a person that we would recommend biomarker testing in. But I like your idea of following him. He's got concerns, he's got risk factors. And so rather than just send him away, maybe a 1-year follow up. Greg, anything you do differently?
I think that that's fairly amazing when you get three folks like us together in a room that there's really universal agreement here. I find for these folks that that is a plan to follow them longitudinally with repetitive screening so that we can stay one step ahead of the game provides tremendous reassurance to our patients that we've taken their concerns seriously and we are doing something, and that can just alleviate so much of the anxiety and worry if no one was addressing it or if they were given a complete dismissal. You're fine, go away. And so really it's very therapeutic. So I'm ecstatic that we're all on the same page.
That's great. That's good. All right. Thank you. So let's go to a final case now. 84-year-old gentleman, so we're going up in age here, hypertension, chronic renal disease, forgetting important dates, taking longer to get tasks done, has some word finding difficulties, but still independent in all instrumental activities of daily living. He's got some recent anxiety and depressed mood. He also snores, and he's concerned that he might have Alzheimer's and wants to get tested. Michelle, let me hand this to you. Where would you start?
Well, first, I would start again with having some type of a objective cognitive assessment. And then if it, comes back, there is certainly impairment before jumping to a biomarker. Anxiety, depressed mood, depression might play a role if it may be untreated. So looking more into that. Also, the fact that he snores, if he hasn't had a sleep study in the past, obstructive sleep apnea is very common and can also contribute to cognitive symptoms as well. So once you rule those things out, then I guess the next question is, well, do you have a biomarker if the person's definitely cognitively impaired and not due to some of these other causes? And this individual does have chronic kidney disease. And so as a result of the poor renal function and poor filtering, we would expect this individual to have elevated levels of any blood biomarker that you generally look at. And so it is still possible that you could use a blood biomarker if it comes back negative. That's very, very clear that they don't have Alzheimer's pathology in their brain. But if it does come back positive, it is possible that it could be a false positive. And so, particularly in this type of patient, you would want to have confirmation with CSF or amyloid PET, particularly if they might be eligible for a monoclonal antibody.
Exactly. So many comorbidities potentially, and a reason to steer away from blood biomarker if we do go that route. Anything else? Any other thoughts, Greg?
I do think, hypertension and vascular risk. So, of course, we would have in that initial workup not only addressed those other medical comorbidities, but gotten that brain scan to look for cerebrovascular disease. And I think one of the questions that I get frequently when working with some of our general practitioners, our primary practitioners here, is at what level of chronic kidney disease do we need to really begin to worry about these tests? I don't think we have real good data on that right now. I really look at the GFR, the glomerular filtration rate, and I typically tell them you should be concerned if it's below 30. If it's just mildly reduced, it's probably not going to make a big difference. But I do think you always need to approach those blood tests with that caveat that even mild renal dysfunction, until proven otherwise, may be altering your results. I don't know, Michelle, if you or Sharon take a different tact when it comes to, well, how's the renal dysfunction really going to affect things at what level?
Yeah, I've been asked that several times too. And when you look at the correlation between renal function and these blood biomarkers, it's quite linear, even in normal ranges. And so it's really hard to say, well, don't use it after an EGFR of X, Y, or Z. I think the importance is really like with any other blood test that's out there, putting it in context. So just because it's even slightly above, that doesn't mean it's definitely positive and the end all be all, but thinking about it in the context of other symptoms. So certainly if you have somebody with chronic kidney disease and they have mild dementia and their blood test comes back and they're just barely positive, well, it's unlikely that Alzheimer's disease is probably contributing to it, given they already have mild dementia and their kidney disease probably increased the levels a little bit too.
I was speaking with a group of geriatricians recently, and they wanted me to know, in no uncertain terms, that most of their patients have at least mild renal insufficiency, that this is so common, and they wanted a cutoff. And of course, Michelle and Greg, as you explained, it's not quite so easy. It's rather nuanced. But if you have the opportunity to access a different biomarker modality in someone with renal disease, that's ideal, but we don't always have that luxury.
Yeah, another thing to think of though is that we don't necessarily want to say just because you have renal disease, don't do a blood biomarker test. Because in many of these individuals, it will come back negative, and that's very important knowledge as well. It's just if it comes back positive, you can't necessarily say for sure that they have underlying Alzheimer's disease. It's like any other type of screening test or for other diseases as well, where you typically follow up. But that negative test would be really helpful.
Yeah, that's a great point. Thank you for that. So, some key take home messages. Timely, accurate diagnosis is required for optimal management of Alzheimer's disease. Biomarkers can confirm a biologic diagnosis of AD, but do not replace the need for clinical evaluation, including disease staging clinically and impact of comorbidities. Alzheimer's biomarker testing is currently not recommended for asymptomatic individuals outside of prevention trials. We didn't talk about prevention trials, but clearly there are prevention trials that are of value. That's different from day to day care. The selection of specific cognitive tools and of biomarker modalities should be individualized to the patient and setting, with the pros and cons recognized for each cognitive test as well as biomarker modality. Thank you, Greg and Michelle, for this great discussion today. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.